system, most of it's going to be anatomy. We are going to talk about the different exam types, but most of the biliary system is going to be anatomy. There are drawings on the test, so you've got to know the anatomy. So in the urinary system, of course, we have two kidneys most of the time. They're relatively equal in size. They may be a little bit different, and once in a while you may have a patient who has a very small kidney. You may have somebody who has one small kidney and one large kidney. The large kidney kind of compensates for the small kidney. And then once in a while you may have somebody who has what we refer to as an ectopic kidney. Ectopic just means it's out of place. If you have a patient who has had a kidney transplant, then naturally it's going to be ectopic. What they're going to do with the transplanted kidney is put it down in the pelvis. And the reason for that is because, I mean, that's where your urine's got to go anyway, right? So instead of trying to thread the ureter from way back here all the way down into the bladder, or not, well, yeah, the ureter into the bladder, they're just going to put it almost directly on top of the bladder. So kidney replacements, replacements, may sound like a car part, but if they've had a transplant, then that should show up in their history, and that's where you would look for it. So generally 2 kidneys, 2 ureters, 1 urinary bladder, 1 urethra, and that's what we call the excretory system. And the word excretory is going to come into play here in a bit. We've got about 4 different words that we use for a study of the entire urinary system. So be ready for all that. So bean shape, that's why we call kidney beans, because they're kind of shaped like a kidney. So they're convex on the lateral border, concave on the medial border, and they're divided into upper and lower poles. But for the most part, your questions are really going to be asking you more about the different things inside of the kidney that we're going to take a look at here in a second. So they're retroperitoneal, meaning they're behind the peritoneum. The superior aspect is more posterior than the inferior aspect, which is going to come into play not just with normal anatomy, but also whenever we get into semi-abnormal anatomy. The lower poles being more anterior, sometimes kidney stones will settle in the lower portion of those kidneys, the cavities inside of the kidneys that have a hard time coming out. So we do have a condition, I'll just go ahead and drop this now. It's what we refer to as horseshoe kidney, where both of the kidneys are not only slanted back a little bit, but they lean towards each other, and the lower poles actually fuse or are fused. And as a result, the ureter coming out has a bit more difficult time getting the urine out, and therefore those patients are more prone to kidney stones than somebody who doesn't have a horseshoe kidney, let's say. So the superior aspect is more posterior, and they're also in a bit of an oblique plane, so that they're not, we have a tendency to think of our anatomy as being kind of, almost two-dimensional, where the kidney's just straight up and down like this, and it's not. Upper pole is back, and then it's rotated a little bit this way so that it faces a little bit towards the side, all right? So the orientation of the kidney, I'll get something bigger so that you can see a little big pink thing. So it leans back a little bit, and it's kind of off to the side just a little bit like that, okay? So we're gonna do some views when we do an IVP that's going to make a difference, and we'll talk about that when we get to it. And then they extend from about T12 to L3. The right kidney is a little bit lower than the left, and that is because, again, of the liver. The liver kind of pushes everything down. So the individual portions of the kidney, what we've got is the renal capsule, that's the outer portion. The cortex is just inside of that. The medulla is just inside of that. And then what we get to is what we refer to as a collecting system, and that is the renal columns and the nephrons being the functional part of the kidney. That's where all the magic takes place, where we get reabsorption of fluids or excretion of too much fluid, where we attempt to make some sort of homeostasis out of the amount of salt that you maintain versus what you eventually excrete. Okay, so the nephron being the functional portion of the kidney. So you'll probably have an image like this on your test, and the important parts are, you know, the renal capsule, renal cortex, renal sinus, not quite so much the medulla. The pyramids are where the nephrons are, and then what we've got are the collecting systems, and that is what we refer to as where the pyramids empty are into what we refer to as calyces. So a calyx is just a cavity within the kidney where the nephrons dump the fluid. So we have minor calyx and major calyx. And a minor calyx is just single, right? And then a major calyx is any calyx where we have two or more, so multiple calyces. So major calyx, minor calyx, and that's major because you've got two different ones. So this expanded portion of the upper portion of the ureter is what we refer to as the renal pelvis, and it's continuous with the ureter. So it's kind of like a funnel. So what happens in a lot of cases is that, you know, just around the lower pole of the kidney, the ureter is pretty consistent in size. It's pretty thin. So it's used to transporting only fluid, then all of a sudden you get a kidney stone, and kidney stones, if you ever see one, you can understand why it is. You know, see, not on x-ray, but you actually see one in surgery. You kind of understand why they're potentially so painful. And that is because a lot of them have little points sticking off of them, almost like a sticker burr. Okay, so if you stepped on it, it wouldn't really hurt you, but if you got a structure that's just used to passing fluid, and then you've got not only a solid, but a prickly solid running down it, it's gonna hurt, right? So the ureter, once it gets down to its normal size, it's gonna take some twists and turns and bends, and in those bends, that's where the kidney stone, if it doesn't make it to the bladder, is probably gonna hang up. So this area right here is what we refer to as a hilum, and remembering back to the liver and back to the lungs, a hilum is just a place where you've got a lot of traffic coming in and out of an organ system. And that's what we've got here. We've got arterial blood supply coming in, venous blood supply coming out, and then you've got the renal pelvis also coming out of the same area. So it's just a basic hilum. All right, so we got a lot of nephrons in each one. We can kind of go through all this. We're not going to be that specific on the test, but that's what your nephron looks like. You got your glomerulus capsule. You've got from your A&P class, I think everybody, I think pretty much everybody in this class has already had A&P 1 and 2. So this should, be familiar to you, afferent vesicles, efferent vesicles, and all that stuff. Okay, so the collecting tubes, again, we just took a look at all of that. Calyces, cups, shaped stems that enclose one or more of those collecting, or the papilla where the nephrons dump, and minor calyces join together to form major calyces. And we just looked at all that, and it was that end. So the ureter, depending on how tall the patient is and what their anatomical construction is, can be 10 to 12 inches long, and again, it kind of twists around. It goes across the transverse processes and over the top of the iliac crest. It takes some bends before it gets down into the bladder. And it plugs into the kind of the inferior posterior portion of the bladder. All right, so it's kind of off to the side. Posterior, inferior portion is where the ureter's set, and we'll take a look at that here in a second. So the bladder is just a sac. Anytime you see bladder, that just means bag. So it's a urinary bladder in this case. It's just reservoir until you can get to the restroom. So located directly above the symphysis pubis, the apex is anterior superior, and the neck is the lowest portion. So where we see not really pathologies, but trauma of the bladder is in patients most of the time who are in high impact collisions and they've got a full bladder. Sometimes what we can have is a rupture of a portion of the bladder. What happens is that the neck doesn't move a whole lot, but it tears away, and sometimes what we get is actually a rupture of the urethra. Just sounds awful, doesn't it? And so what we wind up with is, they can't pass a catheter to drain the patient's bladder, so what they'll have to do is put a suprapubic catheter into the patient. So remembering exactly where the bladder is, it's just superior to the symphysis pubis. What they'll do is they'll they'll actually poke a hole in the patient's lower abdomen, right above the symphysis pubis, into the bladder, and put a catheter in that way to drain the bladder. And you might be thinking, okay, well, what if they have a total bladder rupture? And that happens where the bladder just, you've got a hole in the bladder that's got to heal up. Well, urine's going to leak out into the abdominal cavity. But the thing about urine is that even though it's waste, it's sterile. And as long as you don't have kidney infection or anything like that, unlike leaks in the bowel, leaks in the bladder are really not all that big a problem. So most of the time, unless the patient has a kidney infection or something else, some sort of complicating issue, then that rupture is painful, it's inconvenient, but the leak of the urine into the pelvic cavity is really not going to do the patient a whole lot of damage. So there is the place where the three openings meet. You got your two ureters, and the urethral orifice is what we refer to as the trigone. And it is this area right here. And it's not as flexible as the rest of the bladder. So everything else collapses, kind of like the stomach. Whenever it's empty, it collapses down, but this is less elastic than the rest of that. So where you get the stretchiness is everywhere except for this triangular area at the base of the bladder. So you got your urethral openings here, ureteral opening here, and just, so if you haven't been to surgery yet, you will go to surgery. And one of the things some of the things that we do in surgery is they'll do a cystogram where they go in and look at the bladder. They'll do a cystourethrogram where they'll cannulate or put some sort of catheter right at the opening of the ureter. I said ureterogram, ureterogram, and inject contrast all the way up into the kidneys, and that's what we call a retrograde pyelogram. But we can do also in the X-ray room, we can do what we refer to as a voiding cystourethrogram, where we inject contrast just into the bladder, and then pull the catheter out of the patient's bladder and watch for reflux up the ureters. And we'll talk more about that here in a bit. There's a specific demographic that sees those exams, so we'll talk about that here in a bit. Okay, so the urethra is just to convey the fluid outside of the bladder, outside of the body, and obviously it differs in length among men and women. The prostate is not really a urinary organ, but because it surrounds the urethra, it's usually included. So its whole purpose is just to create semen, and it's not a part of the urinary system. So what we're going to talk about are contrast studies. We're going to talk about the different contrast media. We're going to talk about reactions to look for. And your textbook breaks your reactions down into mild, intermediate, and severe. I'm telling you, if you have a patient that shows any kind of reaction, you need to get somebody in the room immediately, because one reaction can feed into the next, and next thing you know, you got a patient in full anaphylaxis on your X-ray table. You want them off as quickly as possible, right? So we'll talk about prep, and we'll talk about the equipment as well. So in contrast studies, what we're trying to show is the parenchyma, or outer portion of the kidney, and we want to see patency of the ureter and make sure that the ureter's open so that we can pass urine from the kidneys all the way down into the bladder. So what we're going to do is we're going to inject the patient with contrast, and right away, blood circulates through the body about once a minute. So right away, the kidneys are starting to pull that. It's iodinated contrast. It starts to pull it out of the blood flow, and right away you should start to see the kidneys a whole lot better. So you inject the patient, you shoot an image right after you finish injecting, and you're starting to see the contrast collect. So there's two different ways that we're going to look at the kidneys. One is a functional exam and one is not. Okay? So your functional exam is going to be antegrade. Antegrade just means going with the flow. Retrograde, like what we talked about before, means going against the flow. So if we're looking for specific things like reflux, whether or not the patient, whenever they urinate, they have reflux going back up their ureters, then we can do a retrograde exam. We could catheterize the patient, put some contrast in the patient's bladder, pull the catheter out, have the patient urinate, and see if the contrast goes back up into the kidneys. So that will be a retrograde exam going against the flow. Antegrade is we're going to inject the contrast into the patient's veins, and we're going to watch how well the kidneys pull that contrast out of the blood flow. So antegrade and retrograde, and we've got a lot of different studies we're going to talk about. All right, so here's where I was talking about before. Higher concentrations of contrast are used for excretory urography compared to retrograde bladder studies. With the excretory exam, and that is an antegrade exam, what we're going to need is about 100 cc's of contrast. Right? With the retrograde filling just of the bladder itself, we might not need that much. So it kind of depends, especially if it's a younger patient, we might not need quite that much. They may elect to completely fill the bladder up, and the bladder can hold up to, 800 cc's, so it's a pretty good sized sac. So we've got two different types of contrast, and we got to cover this, but I haven't seen or heard of in practice they're both iodinated, but one's non-ionic and one is ionic. All right, and I have not seen the ionic used in a long time. So the reason we use the non-ionic is because it has a lower rate of adverse reaction. So the patient is most likely to react to the ionic contrast than what they are the non-ionic. I've never seen any reaction to either one, fortunately, but it could happen. It's more likely to happen with the ionic. I'm sorry. So as a result, probably most common contrast you're going to use for antegrade exams is non-ionic. If it's retrograde, you might use ionic. So whenever you get your patient, if you're doing CT or if we make a swing back to doing a lot of IVPs, which is what we're going to talk about here in a minute, intravenous pyelograms. We'll get to all the other excretory urogram. That's what I was looking for. Mean the same thing. They're the same exam. IVU, IVP, EXU, all of those things mean exactly the same thing. So you've got to take a good history on a patient. And what you're going to hear people asking them is, are you allergic to iodine? That's a good question, right? Some of them will ask, are you allergic to eggs, strawberries? Really the best question you can ask them is, are you allergic to any other kind of medication? That's really the most, if a patient is likely to react, statistically speaking, they're more likely to react if they're allergic to other medication. All those other things are good to ask the patient, but make sure you ask them, are you allergic to any other kind of medication? Some diabetic medication doesn't go well with our contrast, so make sure you ask them if they're diabetic as well. So our retrograde exams, though, again, we can use, in some cases, some ionic. And just because the non-ionic has a lower rate of adverse reaction doesn't mean somebody won't react to it. So some people say you don't even need to ask them if they're allergic to iodine, because the body just on the non-ionic doesn't react the same way as what it would to iodine. But I'm telling you, we had a biomed guy at ETMC that if he walked into the room, there was anything drawn up in a syringe, he was backing out of the room and he was saying, I need to know what's in that syringe. I need, if it's iodinated contrast, I need it out of the way. He'd just touch the syringe and he'd react. So some people are highly allergic, and you need to know that. This is something, I know I'm kind of badgering this point, but this is something that you can't pass up. If you're doing any kind of injectable, you have to ask the patient, are you allergic to any other kind of medication? Are you allergic to iodine? Are you allergic to, throw in whatever you want to, but make sure you ask them, are you allergic to any kind of medication? Okay, so get that. Also, if you're doing a retrograde exam, because he was so sensitive to it, if we'd have injected contrast into his bladder, it would have been bad. So get that information from the patient for the retrograde exams as well. So adverse reactions, usually mild and short duration. Some of your reactions are not truly reactions. So, Merrill says there's 3 types of reactions. I'm going to tell you there's 4, really. You've got mild, intermediate, and severe, severe being anaphylaxis. But you've also got what we refer to as placebo reactions, okay? So for these exams, because we're putting something potentially harmful into the patient, we have to get an informed consent from the patient, and you don't do that, all right? So who needs to do that is PA, radiologist, somebody else who knows the patient's history a little bit more and what their potential outcomes are, so that they can suggest alternative exams. Okay, so the patient should come to you with an informed consent. So we inject the patient. If we inject the patient, or before you inject the patient, you're going to ask the patient the questions that you need to ask the patient, and you need to describe what's going to happen. But what you don't need to go into in depth is your potential interactions. You don't want to be holding the patient's lure lock, screwing your syringe onto it and say, you could die from this, right? Because now what's the patient thinking? I'm gonna die, right? And they can talk themselves into some sort of reaction. 2 things that you might want to warn the patient of. One is that whenever you inject the contrast, what you're doing is you're increasing the patient's blood volume by 100 cc's. Those big syringes, big cap tip syringes, are 60 cc's. We're going to put 2 of those in an adult. So your heart has to react to that, right? It's suddenly got too much fluid in it just, within 2 or 3 minutes injection. So you need to tell the patient your heart may race a little bit. You might feel a little bit flushed. And I won't get too graphic here, but certain parts of your body might feel a little more flushed than other places. In fact, a lot of people think that they pee on themselves. Okay? So warn them of that, but don't sit there and badger the point, this could kill you, You really want to do this? This could kill you. They should have already been through all that, right? But do warn them about the other things so that, they kind of know that that's normal and that's not a sign that they're actually having a reaction. So these are just the types of reactions. You need to make sure that you've got somebody present, a radiologist close to administer medication if the patient goes south, nurse, somebody that is more familiar with medication than what you are. If the patient starts to feel a little lightheaded, in a lot of cases that again is a consequence of injecting 100 cc's into the patient. So it's not all that big of a deal, but if they start going down this list of nausea, vomiting, especially if they get to the point where they, if you hear a wheeze, you need somebody in the room, right? So if they really start going down this path, they're headed potentially towards anaphylaxis, and at that point, you need somebody already on their way, if not in the room. So make sure you have your crash cart up to date, make sure that you've got all the medication and personnel available. And if you have any inkling that something's going bad, just go ahead and call. All right, so preparation, it depends. If we have a patient that comes to the ER, which really a lot of our kidney stone patients are gonna come from the ER, there's not a whole lot you can do, right? But if the patient knows, you know, if it's a scheduled exam, then we're gonna do something kind of like an upper GI. We're gonna do low residual diet, maybe an enema, maybe laxatives, things like that. But at the very minimum, NPO after midnight. Scheduling, again, the patients that are potentially diabetic, first thing in the morning, try to get them out of the way so that their sugar doesn't, you know, give them a hard time. Also, if we're doing a barium study, we have to start with this. Because it's iodinated contrast, it's not as dense as barium. If we put barium in the patient and follow it with iodine, you're not gonna get a study at all. If you start with iodine, the iodine's gonna be gone before you start with barium, okay? So you gotta start with the iodinated exams before you get into the barium exams. Okay, so just more patient preparation. You know, hydration. Also, patients with multiple myeloma, you probably might be asking about that. Take a look at patients' BUN and creatinine levels, their kidney function tests, and make sure that they're, you know, they're good. Normal BUN and creatinine, you know, if you got above 20, that's, you need to present it to the radiologist. But if you're above 20 and I think about 1.5, that really needs to be brought to the radiologist's attention, because it indicates that their kidney functions are running a little bit low, and there may be a pathologic reason for that. So, all right, kind of talked about this. We might need some time markers. You're going to shoot. Once you inject into the patient, you're gonna shoot multiple exams, usually 5 minutes apart. And you're gonna do some obliques, and you're also gonna have the patient get up, go to the restroom, urinate, come back, and you'll take, in this case, it's a post-void. It's not a post-evac, that's colonic. So post-void is the last view that you take. And some of your radiologists might want you to shoot that one with the patient upright to look for bladder prolapse. See if the bladder is, especially in moms, another thing your kids give you is a nice bladder prolapse in some cases. So I want you to do it upright. And then your venipuncture supplies, talk about that real quickly. So your venipuncture supplies, some of your hospitals are gonna have nurses on staff that are gonna take care of the venipuncture for you. Some will not. So the bigger the hospital, in a lot of cases, you're gonna have that available to you, but if you're working in CT or if you're working in a smaller hospital, you may have to start IVs on patients. So I think that's your lab this week, is that y'all are gonna be in here doing IVs. You're not gonna be sticking each other, I don't think. We've got some dummy arms that you'll poke. So a couple of things about the venipuncture. You know, the equipment type that you're gonna use, you may use some butterfly needles, and butterfly needles are just like that. It's got a needle sticking out of it, and it's got 2 wings. You've probably seen this if you've had your blood drawn. You kind of pinch the wings up, and that's what you hang on to whenever you start the IV. So 2 things to remember. One is the needle size. So any hunters in here? Anybody? Okay, ish. All right, so shotguns. The bigger the number, what can you tell me about it?
The smaller the bore.
The smaller the bore. The larger the number, the smaller the bore, okay? So you're looking down the barrel of a shotgun, a 12 gauge has got a great big hole, and a 20 gauge has a smaller hole, so it goes in the opposite direction. Needles are the same way. 18 gauge needle is big fat needle that you don't want to get stuck with, but you do want to use that to poke into the port into the IV. Okay, so what you want to get stuck with is something more like a 22 gauge. It's a little bitty tiny needle. Okay, so what that describes is the size of the bore. All right, and then whenever you do your venipuncture, you want to stick the patient. It seems a little bit counterintuitive, but with the bevel side up. What I mean by that is that the needle is cut, so you've got this tube and it's kind of cut down like that. Okay, that's your bevel. So the bevel is going to be up. Okay, that's the reason I say it sounds kind of counterintuitive is because if the bevel is up, it would seem like that as soon as you poke a hole in the patient's just going to spurt blood, and it's not going to happen, right? So you might think, well, if I put it down, then I'm good. But no, you want to put it up. Okay. So have all that available. Make sure that you've got alcohol available to wipe the whatever it is you're injecting, whether it be the patient directly or the IV. All right. So we're going to talk about image quality, motion control, ureteral compression, which is something that you might use in certain circumstances. If you got a patient with suspected kidney stone, you don't want to do that because you could potentially push the stone through the ureteral wall, and we'll talk about the preliminary examination and the radiation protection and all that kind of stuff. So motion control, for the most part, we're going to use as short an exposure time as possible. Remember what we were talking about on Wednesday, reciprocity? What was reciprocity?
Goes up,
Yep, goes up and down. It's give and take, right? So it's what we're going to use is a higher MA value with lower time to limit motion. Sometimes patients, because they have kidney stones, are going to be in a lot of pain. And when you inject 100 cc's of contrast, what that's going to do is again going to increase the blood volume in the patient. But what that's going to do is going to put pressure on the kidney stone. The patient's going to have a tendency to want to squirm around. Okay, so short exposure time, if at all possible, so that you can mitigate some of that motion, be it involuntary or voluntary motion. You can make an argument, well, the patient can't help it. They're in a lot of pain. They're moving around. Okay, you want to call that involuntary motion, that's fine. Also, sometimes if patients in a lot of pain, I've seen this happen as well, the ER doc may give them some pain medication. And if they are even slightly prone to hypochondria, you give them medicine and they're already in pain and they can't go off the charts. So some of the worst exams, IVPs I've ever had were patients who they medicated because they were in pain. The medication made them paranoid, and then we injected the contrast. They felt their heart speed up. They truly, truly thought they were going to die. Placebo reaction. Horrible study. Might as well just send the patient to CT. Might as well send me to MRI. Just not going to get a good study. Okay. All right, so if we use ureteral compression, the purpose for that is to keep the contrast up in the kidneys as long as possible. So sometimes you inject the patient, and what you find is that the contrast starts down the ureter before you can make your 0-minute film. So what we do is we inject the patient, we do a scout. A scout is just KUB, and we're just looking for placement of the kidneys. Do they have ectopic kidney? Whatever, right? So we do the scout, we inject the contrast, and then we take what we refer to as a 0-minute or an immediate image. And what we should see is that parenchymal blush of the kidneys. So it's starting to pick up the contrast, it's starting to pull it out, right? And sometimes it'll already start to come down the ureter. So what we want to do is to slow it down a little bit, and what we can do is put compression devices And where we'll put those is just medial to the ASIS. Okay, so ASIS is right there. So what we're trying to do is we're trying to put these compression devices so that it will push back into the soft tissue of the abdomen and compress all that and kind of squeeze off the ureters a little bit to try to keep some of that contrast up into the kidneys. Now what the compression device is going to have is really three things. It's going to have a belt that goes all the way around the patient, and it's got Velcro on it. It's going to have a hard plate, and then where you put these, they're kind of like inflatable pads. You put those underneath the plastic thing to push, again, back, just medial of the ASIS to push back into the hard surface of the pelvis, all that soft tissue to try to compress it and keep some of that urine from flowing from the kidneys into the bladder too quickly. Another option, if you don't have that, is to just flip the patient over on their stomach, shoot a KUB, but shoot a PA, because most of your patients, already have the fluff to mash into the pelvis, right? So one way to accomplish this, if you can't find a compression device, is just lay the patient on their stomach. What you don't want to do is, if the patient potentially has a kidney stone, which again is the most common reason that we're going to do this, you don't want to use the compression device, because in doing so, what you could do is you could push that kidney stone through the wall of the ureter. Now, if you flip the patient over onto their stomach, could that happen as well? Yeah, but if the patient's hurting that bad, if you flip them over onto their stomach, they're probably going to relieve some of that pressure. You're probably less likely to accomplish that. I say that like it's an accomplishment. You're less likely to have that complication, I guess is a better way to say it. Okay? So, compression. Just to slow the flow of the urine into the bladder. All right, so contraindications, urinary stones, that's the most common reason that we do this. Abdominal mass. If the patient has an aortic aneurysm, you need to show that image to the radiologist right away. And sometimes aortic aneurysm is going to be hard to see, but if you shoot your KUB, you know what the spine's supposed to look like, right? Mm-hmm. If you see anything poking out on either side of the spine that you've never seen before, somebody needs to look at that image. Had a patient one time, I was a clinical instructor again at ETMC, and the spine, here, and we shot the scout image, and we saw the shadows sticking out about that far on either side of the spine. And if we'd have injected that was abdominal aortic aneurysm. If we'd have injected that patient and increased their blood volume by 100 cc's that quickly, increasing their blood pressure, then there's a very real chance that that aneurysm would have burst and the patient would have been dead within a minute. So if you see anything sticking out on either side, that truly is a contraindication for injecting the patient. We took the patient around to CT, did a minimal study injection, and the patient had a surgery at Mother Francis the following day. So other things, colonoscopy possibly, colonostomy, suprapubic catheter, traumatic injury, some of those things we're probably going to do some other exams for, and they would be not a good candidate for ureteral compression. All right, so respiration, most of the time we're going to shoot on full exhalation. If you're a radiologist, the preference of the radiologist in the hospital is shoot on inspiration, then go with that. Just know that all the way through the registry, the answer on any test that you take is for an IVP, KUB, whatever, you're going to shoot on expiration. And the reason for that is because of those interactions that we've been talking about in imaging and radiobiology. The thicker the tissue, the more likely you are to get a scatter event, right? So even with inhalation, even though you don't gain any fat with inhalation, what you do get is the diaphragm pushing down on your abdominal contents. And where does it go? Right? It goes straight out in front. Okay, so you're going to create more scatter with the patient on inhalation, but some of your radiologists want you to shoot on inhalation so that it pushes those kidneys down. I'm not saying it's wrong. I'm not saying it's right. You know, it's their insurance, that their medical malpractice insurance that they're having to pay for. So, you know, shoot on whatever phase of respiration that they ask you to, but the test answer is what phase? Always expiration, okay? So, all of that. You shoot a scout, that's just KUB. If the patient's really tall, you might have to shoot a second scout just to show the kidneys. And what you're looking for really is their position, contour, shape, any kind of pathology that may stand out. Radiation protection. Understand, I think Amy said that shielding has really come off of the registry, so we're not really even talking about it anymore. So really your radiation protection is going to be your collimation. You want to collimate in as tightly as possible while making sure you include all the important anatomy. All right. So, urinary procedures. So we've got intravenous urography, that's IVU. That's the same thing as an IVP, intravenous pyelogram, which is the same as an EXU, excretory urogram. Okay, all of those things mean the same thing. You just need to write them down. I think there's a question on the test that has all of those as potential answers, so, or at least two of them anyway. So tomography, we're not really going to talk about. We will talk about the different types of retrograde urography, which we've talked a little bit about, cystography, and then cystourethrogram. We'll also talk about as well. So all of those demonstrate the function of the kidneys. So retrograde exams do not show the function of the kidneys. It's only antegrade exams. Okay. Risk factors: multiple myeloma, diabetes, sickle cell, elevated BUN and creatinine levels, all that kind of stuff. One more creatinine, 1.2. Alright, so what we're going to do, I'm just going to call it IVP. I'm not going to run through all those exam types. What we're going to do, again, is I've got two kidneys. I've got one very large kidney, one very small kidney. But what we're going to do is we're going to shoot a scout. And the scout's just going to be KUB. You might have to position the scout, or you may have to do two scout images just to get the top, especially of the left kidney. All right, so what we're going to do is we're going to do the scout. We're going to draw up our contrast. We've got all of our patient information. We're going to present it to the radiologist. The radiologist is going to say, proceed. So you show the scout to the radiologist as well. So what we're going to do is we're going to inject 100 cc's for an adult. If we're doing kids, the radiologist is going to tell you how much to inject into the kid. So we're not really going to talk about that. That's going to be patient specific depending on their weight. So what we're going to do then is we're going to take our first image to make sure that we get the top of the kidney. We're going to position it more like an AP of the L spine without collimation. So we're going to make sure it's going to be kind of high. It's going to be positioned kind of like an upright abdomen, right? So go above the crest, about 2 inches above the crest. Make sure you get the top of the kidneys. After that 0 minute image, you're going to take an image every 5 minutes until 15 minutes, and then you're going to do some obliques. So you're going to do a KUB. First off, you're going to do a high KUB at 0 minutes. You're going to do a KUB at 5 minutes, a KUB at 10 minutes, and in a lot of cases, you're going to do oblique. So the obliques show you a lot of stuff. Okay, it's kind of like the obliques of the pelvis when we went through the pelvis last semester. You remember, you can see in the Jude views, you can see the entire pelvis. If you opened up your collimator, shot it like pelvis, right? So the kidneys, again, are positioned where the superior pole is posterior and they're at an oblique angle like this. So at 15 minutes, what you're going to do is you're going to do bilateral obliques. And as you oblique the patient up, what happens to the kidney furthest away from the image receptor?
Opens up.
It opens up. Yeah, you see truly more of a frontal view. I won't say AP because that's projection, but kind of a frontal view. What happens to the one closest to the image receptor? It's pretty much a good lateral, right? So you're going to do bilateral obliques, okay? So you're going to do about 30 degrees, no more than 45. So you're going to do LPO, RPO, and then you're going to wait another 5 minutes and you're going to shoot another one at 20 minutes and show all those to the radiologist. Radiologist probably tell you get the patient up, post-void, and you're done with the patient. The other thing that the obliques show, this is a better bladder. All right, so where do the ureters plug in? Towards the bottom, posterior side, right? So at the same time as you oblique, you get your, let's say your ureteral insertion here, right? As I oblique up, what happens to the side that's closest to the, well, furthest from the image receptor? You gonna see it a little bit better? Yeah. So in a lot of cases where your stones are gonna hang is all the way down at the ureteral orifice, okay? So not only are you gonna see good AP and lateral of the kidneys, but you're also gonna see the ureteral insertion on the elevated side. Okay, so in two views, you get AP and lateral of both kidneys and you get both ureteral insertions in the bladder. So make sure that you get, you know, as much of the kidney as possible and then down to the ureteral insertion. Okay, so bolus injection, what does bolus mean? Any idea? What that means is you just push it as hard and fast as you can go. Okay, so the patient's probably going to have a smaller gauge needle in their arm, and if they've already got an IV started, they're going to have a smaller gauge needle in their arm. You're either going to have a lure lock, which is a twist-on thing. Okay, you're either going to have that, or you're going to have a port that you can stick into. Now, here's PSA. Worst needle stick I ever had as far as pain goes. That's just popped into my mind, but you need to know this. So those ports in the IVs have a hard plastic outer portion that's thicker than what you might think it is. Okay, and then it's got that little rubber thing over the top of it. So I'm doing this IVP on this patient. I'm getting ready to inject, and I take my 18 gauge needle and I'm going to poke it in this port. And I'm talking to my patient, you know, just doing the normal stuff. And I look at my syringe with my needle, and I look at the port, and I put them together, and then I take my eyes off of what I'm doing. I'm talking to the patient again. So you start to push something, and you meet resistance. What do most of the time? Push a little harder, right? If you were smart, you'd stop. I wasn't. And I pushed a little bit harder. And instead of popping into the port, it popped out of the port and went into my thumb here. Oh. And if you ever poked like a piece of plastic and on the back side of the plastic before whatever it is that you poke on it, it turns very light in color. Yeah, I pierced my thumb pretty much. I had that little pinprick on the opposite side of it. Went hurt for weeks. Bled like a stuck hog, hurt for weeks. Watch what you're doing, okay? Make sure that the needle goes inside, and then look at the patient and start talking to them. That hurt, it really did. Hurt for a long time. So anyway, that was a rabbit trail, but don't make my mistake. So a bolus injection just means that you inject all of it one time as hard and fast as you can go. And then you're going to shoot a 0 minute. I've seen a lot of techs inject one syringe full, make the 0 minute, inject the second syringe full, shoot 5 minute, okay? So if that's kind of the way you want to go about it, especially if they've used a very small gauge needle, if they've got a 24 gauge needle, you don't really have time to push two 60 cc syringes worth of contrast into the patient before the contrast is going to start coming down the ureters. So in those cases, you might inject one syringe, shoot your 0 minute, and do the next one. Okay? So 0 minute, 5 minute, 10 minute, maybe 10 minutes with obliques, maybe a 15 minute, maybe the obliques at 15 minutes, and then your post-void is going to be a full KUB. If, though, you've got a situation where there's an obvious obstruction, these may drag out a little bit longer. They may want you to shoot before you get the patient up for a post-void, they may have you shoot multiple other images just to see if it's going to move. Okay? So that's your basic IVP. We'll take a look at some images. And here's the thing. IVPs have kind of, CT took over IVPs almost completely for a long time. I'm hearing that we're doing more IVPs now and fewer CTs of the urinary system, depending on patients, what their symptoms are. So for kidney stone, whatever. So some exam types are cyclical. We'll do something like an IVP for a while, and they say, well, studies show we get much more information out of a CT, so we'll do CT for a while. Then insurance stops paying for CTs for kidney stones, so we go back to IVPs, right? So throughout your career, you may see IVPs come and go, okay? So you got to know this stuff. Once we get into the biliary system, unless you're working in a specialty area like special procedures, interventional surgery, something like that, you're just not going to do a whole lot of biliary studies, and we'll talk about that here in a minute. But you probably will eventually do IVP. So hypertensive IVP is just like a regular IVP, only in a lot of cases, instead of injecting quite as much so fast in a bolus, they may do like a drip. So they may hang the contrast and drip it into the patient so that, if they're already have hypertension, you increase their blood volume, it doesn't complicate things. All right, so in those cases too, if you're doing a hypertensive IVP, you may do one image every minute for the first 5 minutes, hypertensive IVP. And then the rest of it's just like every other IVP. You get to the 5 minute, and then you would shoot a 10 or 15 with obliques, and a post-void. That's your drip infusion. Oh, that's kind of ugly. All right. So really all this is just positioning that we talked about before. So, all it is KUB after KUB. So the first one is not a KUB. It's a little bit higher than a KUB, right? And then after that, it's all KUBs until the obliques, and then it's back to KUB. So I don't know what minute this is. I'd say probably 5 minutes since the bladder's not all that full. This patient's full of gas. It's not ideal. Let me make this a little bit bigger so you can see it easier. It's not an ideal study. I don't see a whole lot of feces in there, so I think they probably did a prep. It might be a little bit, but it's not severe. But that's what you should be looking at, is you see how the ureter, it tapers down, right? And it goes across the transverse processes across the pelvis into the bladder. And they're not ectopic. You see the left kidney higher than the right kidney. Everything is fine. Sometimes if a patient has a kidney stone, the kidney stone might lodge right as it comes across the pelvis. What that might do is take the ureter, and instead of having this nice fine line like that, it'll be great big and fat. And if it's been like that for a while, the kidney will swell. And that's what you refer to as hydro, water, nephrosis, neph being kidney, osis, condition of, hydronephrosis is condition of having too much water on the kidney. Okay? Again, most of the time that's because of a kidney stone. All right. So your obliques, you see these things right here, these shadows? Those are your compression devices. Again, the purpose for that is to keep the contrast up into the kidneys. Just slow the flow a little bit. Don't do a whole lot of laterals. As a matter of fact, in my entire career, I've never done a lateral on an IVP, and you can see why. Kidneys pretty much right across the vertebra, and you've created so much scatter radiation you just can't see it up that well. Dorsal decubitus, just don't do a whole lot of. What you can see though on cross-table lateral is that if you shot your scalp and you saw something that looked a little bit weird either over the vertebra or out from the vertebra, what you might do is shoot a cross-table lateral abdomen, and if the patient has an abdominal aortic aneurysm, a couple of things. One is that the best view to see that is on a lateral decubitus abdomen, and number two is that an aneurysm, the body tries to protect itself, right? So you've got this outpouching or the bulging out from a artery in an aneurysm. The body will lay down calcium to try to stabilize that bulge, right? So with it being directly over the vertebra, when you shoot your AP, you just don't see it all that well. But if you see something on the AP that just doesn't look right, and you shoot a dorsal decubitus and you see anterior to the vertebra, you see this calcification in what looks like a tube. Only so many tubes that are going to be directly in front of the vertebra. That's going to be, most commonly, going to be, if it's got calcium in it, your aorta. So common pathologies, we're going to have hydronephrosis, we talked about that. Ureterocele is where a portion of the ureter prolapses into the bladder. Lith just means stones, so urolithiasis means we've got some sort of stone somewhere. So we've got kidney stones, we've got ureteral stones, staghorn kidney stones, and bladder stones. So staghorn, it bears some explanation. All right, so any kind of male deer with antlers, you know, you buy a knife made out of the antler, you call that a staghorn handled knife, right? So, all right, so staghorn kidney stone, when you see one, you'll understand this a little bit better. Let me go back to the diagram of kidney. Staghorn kidney stone completely fills up the collecting system. All right, so you got kidneys here, all right? This is kind of like looking at the clouds and finding an animal, but imagine a kidney stone that's well calcified so you can see it, and it comes out and it goes into each one of these little things and it completely fills that up. Now turn it a little bit on its side and it kind of looks like a moose antler, right? Staghorn. That's why they call it staghorn kidney stone, is because it looks like moose antlers in a lot of cases. So how we get rid of kidney stones in a patient is you'll see this when you go to surgery. They'll use what they call electronic shockwave lithotripsy. It's extracorporeal, but electronic is just easier to say. So what they do is they use sound waves to break up a kidney stone. So if a patient has a kidney stone stuck right here, then they can use sound waves to break that up. It'll shatter the kidney stone. They'll probably put a stent to keep the ureter open, but they can shatter that kidney stone and the patient will pass it. If a patient has a staghorn kidney stone, they can't do that. They would destroy the kidney with as many shock waves as they'd have to give to the patient. So what they'll do is what they call a percutaneous nephrolithotomy. So they poke a hole in the patient's back and they go in there and grind it up and drain it out. Okay, so staghorn kidney stone. Let's see if I can find my slide again. There we go. Staghorn kidney stone. Ureteral stones, just stones in the ureter. Nephroptosis, we talked about, double collecting system. A double collecting system is where we've got a patient who has two renal pelvises and two ureters, okay? So sometimes those ureters join back up close to the insertion in the bladder, and some will have a secondary insertion into the bladder. And sometimes a patient with a secondary insertion, they don't really have a sphincter to prevent reflux, and in those cases what we have in that patient is recurring kidney infections or urinary infections. So cystocele, just prolapsed bladder, and then horseshoe kidney is what I was talking about before. And because of the horseshoe kidney being fused at an odd angle and the way the ureters come off of them, those patients are more prone to having kidney stones, even the staghorn kidney stones. So there's some pretty nasty hydronephrosis. Moms in here? Okay, one or two. Sometimes kids will sit just somewhere perfectly while you're pregnant and mash a ureter so that you get hydronephrosis from it. So it's rare, but once in a while we'll have to do an IVP on a pregnant patient. And in those cases, what we're going to want to do is use higher KVP, lower mass, save patient dose, possibly shoot PA. Okay, rare, very rare. I think in my entire career, I've only seen one. Ureterocele is what we refer to as cobra head appearance or cobra head sign. That's where the ureter comes down and you've got just kind of some prolapse into it. Ureteral stone, staghorn kidney stone. This patient's got a lot going on. There's some pretty severe scoliosis as well. Bladder stones, nephroptosis, that's your kidney way down here. Dual collecting systems. So again, prolapsed bladder, we've got what we refer to as a cystocele. Staghorn, or I'm sorry, horseshoe kidney. So they should not be fused at the bottom, but you can kind of see how they lean back a little bit, right? So, all right, so again, we're not going to talk about nephrotomography, but I do need to talk about voiding cystourethrogram. All right, so never done one of these, and there's good reason for it. So if you've got a pediatric patient, and the history is usually young girls. If you've been through A&P 1 and 2, you know that most pathologies are, affect males more than females, but in this case, it goes the other way. It's more little girls than little boys. So if you got a little girl, and any kid, but especially a little girl, and she's not growing at the rate she needs to be growing, and she's not gaining weight, not growing in any dimension the way she should, and she's having reoccurring kidney infections, that could be an indication that she's got reflux, consistent chronic reflux. And it's what we call failure to thrive. They're not growing, thriving the way they should. So that's your population, most common population. Little girls, most of the time, smaller than what they should be. All right, so what we're going to do with avoiding cystourethrogram to diagnose that reflux is we're going to have the patient come in, we're going to catheterize the patient and inject contrast into the patient's bladder, and then once under fluoroscopy, once a bladder is full, we're going to pull the catheter, deflate the balloon, pull the catheter, and fluoro as the patient urinates, and watch and see if we have any reflux going up the ureters back into the kidneys. So think about that. What's our population? Little girls, right? Little girls, I'm talking about 5, 4, something like that. What have you been coaching this little girl for the last, 2.5 years? Don't pee on yourself. What else? What's that? Don't pee in the bed, all right? Yeah, don't let anybody see that thing. Don't let anybody touch it, right? Now, what are we going to do to this poor kid? All the above. All the above, right? So, guys, it's just probably not an exam that you're going to do because of the population and because it's already traumatic. And it's as traumatic on mom and dad as what it is on the kids. Just understand that there's going to be a preference, and that preference is probably going to be, to have a female tech. If you're the only person on call that night and the exam has to be done, then in that case you might, get selected to do that exam. Otherwise, just let somebody else handle it. Okay? Don't get your feelings hurt or anything. Well, I want to do that. No, you don't. You really don't. You're going to have a screaming kid, a screaming mom, angry dad, and it's just going to be traumatic for everybody. So the point to this is if you have to do a VCUG, pull out all of your patient care skills. You're going to honey baby, sugar sweetie, mom, dad, kid, nurses, everybody who comes in the room. Okay? Pull out all of your patients and your patient care skills for those exams, because they're just off.